There is something about breast cancer that makes it different from the diseases most people fear. It does not always hurt. It does not always create a noticeable lump. And in its earliest stages, it may not give you a warning at all. You can feel healthy. You can be exercising, eating well, going to your annual checkups, and still have an abnormal group of cells quietly growing inside your breast. That does not mean every unusual breast change is cancer. Most breast changes are not cancer. But it does mean something important. Feeling healthy is not the same thing as knowing what is happening inside your body. Breast cancer begins when cells in the breast start growing without the normal controls that keep healthy cells organized. Your breast is not simply fat and tissue. Inside it are lobules that can produce milk, ducts that carry it, blood vessels, connective tissue, and a network of lymphatic vessels and lymph nodes. Millions of cells are constantly being replaced, repaired, and regulated. Normally, that system is remarkably controlled. A damaged cell can stop dividing. It can repair itself, and if the damage is too severe, the cell can be removed. Cancer begins when some of those controls fail. One abnormal cell becomes two become four, then hundreds, then thousands. At first, the number may be so small that you cannot feel anything. There may be no pain, no visible change in the mirror, no obvious difference in the way you feel. And that is one reason breast cancer screening matters. A screening mammogram is designed to look for breast cancer before symptoms appear. In the United States, the U.S. Preventative Services Task Force currently recommends mammography every 2 years for women ages 40 through 74 who are at average risk. But screening is not a guarantee. A mammogram can miss some cancers, and a recent normal mammogram does not mean a new breast change should be ignored. That is why understanding your own body still matters. A new lump, a change in breast size or shape, skin dimpling or puckering, a nipple that changes direction, unusual nipple discharge, swelling, or a persistent skin change. These changes do not automatically mean cancer, but they deserve attention, because the most dangerous mistake is not being afraid of breast cancer. The most dangerous mistake is assuming, if something were seriously wrong, I would feel it. Sometimes you would, sometimes you wouldn't. And to understand why, we need to go one level deeper, because the real story of breast cancer does not begin with the lump you can feel. It begins years earlier, inside a single cell, and that is where body code goes next. Your body replaces damaged cells every day, millions of times. But that replacement system has rules. A cell is supposed to divide when necessary, stop when necessary, and die when it becomes too damaged to function safely. Cancer begins when those rules start breaking. Inside a normal breast cell, DNA contains instructions telling the cell when to grow and when to stop. But DNA can become damaged. Sometimes the body repairs that damage. Sometimes the abnormal cell is eliminated. But if enough important genetic changes accumulate, the cell can begin multiplying when it should not. One cell becomes a small cluster. The cluster grows, and eventually it can form a tumor. But here is the part most people misunderstand. A tumor is not automatically cancer. Some breast tumors are benign, meaning they do not invade surrounding tissue or spread to distant organs. Cancer is different. Cancer cells can invade nearby tissue, and some can eventually enter blood vessels or lymphatic vessels and travel somewhere else in the body. That process is called metastasis. And this is why doctors don't only look at the size of a breast abnormality. They want to know what kind of cells are there, how aggressively they are growing, whether they have invaded surrounding tissue, and whether they carry specific biological markers. Because breast cancer is not one single disease. There are different subtypes. Some grow slowly, some grow much faster. Some depend on hormones such as estrogen or progesterone. Some carry excess HER2 protein, and some do not have those common targets. The treatment can be completely different depending on the biology. So when someone says, "My friend had breast cancer and this happened to her," that story may not predict what will happen to someone else. The biology matters. And now we can see the next problem, because cancer does not become dangerous simply because a few abnormal cells exist. It becomes dangerous when those cells learn how to survive, invade, and spread. And that is what we need to understand next. Your immune system is constantly looking for cells that don't belong: viruses, bacteria, damaged cells, and abnormal cells. So why doesn't it simply destroy cancer? Because cancer begins as one of your own cells. It carries your DNA. It lives inside your tissue. And in the beginning, it may not look foreign enough for your immune system to eliminate it. But cancer can become more sophisticated. As a tumor develops, cancer cells can change the environment around them. They can release chemical signals that alter nearby immune cells. They can encourage blood vessels to grow toward the tumor, and those blood vessels provide something cancer desperately needs: oxygen and nutrients. This process is called angiogenesis. Think of a growing city. More buildings require more roads. A growing tumor needs its own supply network. But there is another problem. Cancer cells can sometimes enter the bloodstream or lymphatic system. Most of them never survive. They're destroyed. They fail to attach to another tissue. But a small number can survive the journey. And if one successfully establishes itself somewhere else, the disease has changed. This is called metastasis. The cancer is no longer confined to the breast. It may spread to places such as the bones, liver, lungs, or brain. And this is why breast cancer is not simply about finding a lump. Doctors need to understand the biology of the tumor. Is it hormone receptor positive? Is it HER2 positive? Does it have other molecular characteristics? How fast are the cells dividing? Has it invaded nearby tissue? Are lymph nodes involved? These answers help doctors determine how aggressive the cancer may be and which treatments are most likely to work. Two people can both hear the words, "You have breast cancer," and still have completely different diseases biologically. That is why modern breast cancer treatment is becoming increasingly personalized. But there is something else you need to understand. A cancer does not have to be large enough to feel to already be biologically important. And that brings us to the signs people notice first. Some are obvious, some are surprisingly subtle, and some changes are easy to explain away. That is exactly why we need to talk about them next. Breast cancer does not always announce itself with pain. Sometimes the first clue is simply that something looks different. A new lump in the breast or underarm is one of the changes people are taught to watch for, but a lump is not automatically cancer. Cysts, infections, and other benign conditions can create lumps too. What matters is a new or persistent change that is unusual for you. Look at the shape of the breast. Has one breast changed size or contour? Look at the skin. Is there new dimpling, puckering, redness, swelling, or a texture that looks different from the surrounding skin? Then look at the nipple. Has it recently turned inward? Is there unexpected discharge, especially discharge that is bloody or occurs without squeezing? These changes can have many explanations, but they should not simply be ignored. And there is another detail that is easy to miss. Sometimes breast cancer causes changes without creating a clearly noticeable lump. The breast may feel different, the skin may become thicker, an area may remain swollen, or the nipple may develop a persistent change. This is why knowing what is normal for your own body matters. But there is an important distinction. Do not turn every breast change into a cancer diagnosis. Most breast symptoms are not cancer. The goal is not fear. The goal is evaluation. If something is new and doesn't go away, a healthcare professional can determine whether you need imaging or other testing. That may begin with a diagnostic mammogram or ultrasound. And if imaging shows something suspicious, doctors may recommend a biopsy. A biopsy is different from a scan. A scan can show doctors that something looks abnormal. A biopsy allows them to examine the cells themselves. That is how the mystery becomes biology. And this is where the story becomes much more precise, because once doctors know exactly what those cells are, they can begin answering the question that matters most. Is this cancer? And if it is, what kind? And the answer can completely change the treatment. Next, we go inside the tests that doctors use to find breast cancer and what those results actually mean. Finding a suspicious breast change is only the beginning. The next question is much more important. What exactly is it? A mammogram uses X-rays to create detailed images of breast tissue. It can reveal abnormalities that may be too small or too deep to feel. Sometimes doctors also use ultrasound. Ultrasound uses sound waves to look at an area more closely. It can help distinguish a fluid-filled cyst from a solid mass. But neither test can tell the complete story by itself. Sometimes an abnormal area looks suspicious on imaging, but it is not cancer. And sometimes cancer can be difficult to detect. That is why doctors use several pieces of information together. If an area looks concerning, the next step may be a biopsy. A small sample of tissue is removed and examined under a microscope. This is where the question changes from, does something look abnormal, to what are these cells actually doing? Pathologists examine the cells for characteristics that help identify the cancer. They may test for estrogen receptors, progesterone receptors, HER2, and other biological markers. These markers matter because they can influence treatment. For example, hormone receptor-positive cancers may respond to treatments that block hormone signaling. HER2-positive cancers may respond to therapies that specifically target HER2. And cancers without those common markers can require completely different strategies. So the word breast cancer is only the beginning of the diagnosis. Doctors also need to know the stage. How large is the tumor? Has it grown into nearby tissue? Are lymph nodes involved? Has the cancer spread to distant organs? These questions determine how far the disease has progressed, and they help doctors build a treatment plan. This is why a diagnosis is not simply a yes or no answer. It is a biological map. And the earlier that map can be created, the more information doctors have to make decisions. Here is where fear needs to become action. Breast cancer cannot always be prevented, and no screening test can find every cancer. But screening can find some breast cancers before they cause symptoms. That matters because cancer is not equally difficult to treat at every stage. When breast cancer is confined to the breast, treatment options can be very different from when it has spread to distant organs. For women at average risk, mammography remains one of the most important screening tools. In the United States, the U.S. Preventative Services Task Force recommends screening mammography every 2 years from age 40 through 74. But your personal situation matters. Family history matters. Previous breast problems matter. Genetic risk can matter. And some women have a higher risk than the average population. For them, doctors may recommend a different screening strategy, sometimes including breast MRI. This is why there is no single screening schedule that is perfect for everyone. And there is another mistake worth avoiding. Do not use a normal screening result as permission to ignore a new symptom. If you discover a new lump, notice a persistent change in your breast, see unexplained skin dimpling, or notice an unusual nipple change, tell a healthcare professional, even if your last mammogram was normal. Screening and symptom evaluation are not the same thing. Screening looks for disease before you notice something. Diagnostic testing investigates something that has already raised a concern. And there is something else you can control. Know your risk. Ask about your family history. If several close relatives have had breast or ovarian cancer, if someone in your family developed breast cancer unusually young, Or if there is a known inherited cancer-related mutation in your family, talk with a healthcare professional about whether genetic counseling or additional screening makes sense. You don't need to memorize every cancer gene. You don't need to become your own doctor. You simply need to know enough to ask the right questions. Because the goal of screening is not to make you anxious every year. The goal is to catch a problem while there are still more options available. And if there is one lesson from everything we've decoded so far, it is this: don't wait for your body to become impossible to ignore. Know what is normal for you. Know your risk. Follow appropriate screening and investigate changes that persist. Because breast cancer can be frightening, but fear does not give you information. Knowledge does.
There is no single decision that can guarantee you will never develop breast cancer. But there is something powerful you can control: how early you respond. Because the most dangerous assumption is not, breast cancer can happen to me. It is, if I had cancer, I would know. Sometimes you would. Sometimes you wouldn't. A cancer can begin quietly. It can grow before you feel a lump. It can exist before you notice a visible change. And that is exactly why screening, knowing your personal risk, and paying attention to persistent changes matter. But don't turn this information into fear. A breast lump does not automatically mean cancer. Breast pain does not automatically mean cancer. A change in your breast does not automatically mean cancer. Your job is not to diagnose yourself. Your job is to notice something different and get it evaluated. Because medicine has something your fear does not: information. A mammogram can look for abnormalities. Ultrasound can investigate a suspicious area. A biopsy can identify what the cells actually are. Pathology can reveal the biological characteristics of the tumor, and staging can show how far the disease has progressed. Piece by piece, the unknown becomes something doctors can understand and treat. And breast cancer treatment today is not one size fits all. Surgery, radiation, hormone therapy, chemotherapy, targeted therapy, immunotherapy. The appropriate combination depends on the individual cancer, its biology, its stage, and the person carrying it. That is why one person's breast cancer story cannot automatically become your story. The biology is different, the risk is different, the treatment can be different. So if you remember only one thing from this video, remember this: don't wait for pain to tell you something is wrong. Know you're normal, know your risk, follow the screening recommendations appropriate for you. And if something changes and persists, don't guess, don't panic, get it checked. Because early detection cannot prevent every breast cancer, but finding cancer earlier can give doctors more opportunities to treat it before it spreads. Your body doesn't always give you a dramatic warning. Sometimes the first warning is simply, something has changed. Listen to that change, not with fear, with action. This is Body Code. Your body has secrets. We decode them.